Okay, Assalamu alaikum. Thank you. Ready? Okay, so today we're going to talk about the anatomy of the gastrointestinal system. I usually don't go into too much detail. I give you the details that you need at this stage. You know, we have a spiral curriculum where you can build your knowledge over the years and by taking different courses and blocks. So don't worry about, getting enough details. Don't go digging into books. Don't overwhelm yourself. Whatever I say in my lecture, that is exactly what you need to know at this stage. Okay, so let's start with this. I guess you have seen this yesterday. Was it yesterday or yesterday? Right? What is this? What kind of section is this? It is sagittal section, which divides the body into right and left, right? As opposed to coronal sections, which divides the body into anterior and posterior. And we have transverse or horizontal sections. Okay, so what do you see in this? This is the nasal cavity. This is the nasal septum, right? So this will be the here nasopharynx, right? And this is the oral cavity, right? This is the hard palate. This is the soft palate, and this is the uvula. What is the uvula? This, right? Why do we need a uvula? Because you don't want food to go up into your nose, right? So this is the nasopharynx, this is the oropharynx behind the oral cavity, and this is the eustachian tube or the auditory canal. This is the opening, right, in your nose or in your nasopharynx. And the function of this is what? Why do you need an auditory canal, eustachian canal? To equalize the pressure in your tympanic membrane, right? That's why we ask you to open your mouth whenever you travel and you feel pressure on your tympanic membranes. You open your mouth, you swallow, whatever, so that, you can equalize the pressure on tympanic membrane. So this is the hard palate, this is the soft palate, this is the uvula, this is the tongue. What is that in blue? This is the epiglottis. It's a cartilage, right? This cartilage is attached to another cartilage here. This is your thyroid cartilage. This is the Adam's apple, right? And it's like this, two plates protecting your, what is that? This is the larynx. That's the vocal cord, right? So area of the larynx and the vocal cords is protected by the thyroid cartilage. And there is another cartilage here. It's called the cricoid cartilage. It's like a ring. So when you do a sagittal section, it's divided into anterior and posterior parts. Okay, they are there to support and protect the larynx and the vocal cords. So, and the epiglottis, which is a cartilage, is attached to the thyroid cartilage. Why do we need this epiglottis? So what happens when you chew, you swallow, your tongue is going to push this down. And the laryngeal muscles will pull the larynx up, so it will be sealed completely so that food does not go there. What happens if food goes in there into your larynx? You choke, right? Larynx, trachea, your lungs, right? And not choke. You might actually die if it is a big thing, right? And so you want to make sure that the food goes towards this tube here. It's like a little opening here. Why it is not big? Because it's a muscular tube. That is your esophagus, right? So esophagus is a muscular tube. It's always closed except when you swallow, right? So then that will initiate the reflex of swallowing. Peristalsis, what is peristalsis? Movement, contraction, relaxation, contraction, relaxation. So food can move down. So today we're going to talk about the esophagus. Esophagus actually starts here at the lower border of this cartilage. We called it the cricoid cartilage. Okay, so exactly here, that's the cricoid cartilage at the lower border of cricoid cartilage. That is the beginning of the esophagus. And from now on, we're going to refer to horizontal levels by referring to vertebral levels, right? We have vertebral column, we have cervical vertebra, then we have thoracic vertebra, then we have lumbar, we have sacral, and we have coccygeal, right? So, for example, this is the first cervical vertebra, this is the second, this is the third, and so on. Okay, so this is the sixth, so we call it C6. So when we say the esophagus starts at the level of C6, meaning that the beginning of the esophagus is at the level of the sixth cervical vertebra. When we say this is at the level of T5, it means it is at the level of the fifth thoracic vertebra, okay? So the esophagus starts here at the lower border of cricoid cartilage, between C6 and C7. And as you see here, it is between the vertebral column and the trachea, right? Below the larynx is the trachea. Okay, so the esophagus is about 10 inches in length, 25 centimeters. It has three parts. Part that is in the neck, we call it the cervical part, and we have part in the thorax or thoracic cavity, and we have the last little part is in the, guys, excuse me, I don't, guys, and I don't care about attendance, really. But I do care about disturbing the class. And I really, really, really hate it when I see people coming in and out. This is not a coffee shop. You don't want to attend, be my guest, don't attend. But if you're here, you're not allowed to leave. If you're late, you're not allowed to come in. If you don't see a value of attending, don't attend. Send me an email, I'll mark you attended. But coming in and out for the sake of attendance, that is something I don't like. I was talking to your class representatives. I'm very pro students. I'm probably the closest faculty to students, as you know, and I lead the MSA as well. It's been, leading the MSA for more than 8-9 years, and people who know me, they know how much I like students and I support students. Conditional respect, and I see it as a sign of disrespect when you come and leave, or you talk while I'm talking. So let's be on good terms, and believe me, you will have my full support. But lecture is a lecture. I don't want any disturbance. Again, if you don't see a value of attending a lecture, don't attend. As simple as that. So the cervical part of the esophagus is in the neck. As we see here, it is between the vertebral column and the trachea. So it's going to be between the vertebral column and the trachea. Sandwich between the two, we have two important nerves. recurrent laryngeal nerves. You know, we have vagus nerves, they are coming from the brain and they carry most of the parasympathetic fibers of the body. 75% of parasympathetic nerve supply is coming from vagus. As they descend down, you know, going towards the abdomen, they remember, oops, we have to supply the larynx. They're gonna send back recurrent, that's why they call it recurrent. It's gonna recur, it's gonna go back, recurrent laryngeal nerve. And as the name implies, it's gonna supply the larynx, okay? So the one on the left is gonna go, you know, this is the vagus. As it crosses the arch of the aorta, it's gonna remember and it's gonna send the recurrent laryngeal nerve on the left side up. The right one is a bit smarter. It's gonna, you know, remember earlier, and it's gonna, you know, give the recurrent laryngeal nerve just below the subclavian artery here. But both vein nerves are sandwiched between the trachea and the esophagus. One of the common complications while doing an operation on the thyroid gland is that you injure the recurrent laryngeal nerve, and because it supplies the vocal cords responsible for movements of the vocal cord, you know, the patient will have hoarseness of voice if it is one nerve. If it is two nerves, might lose his voice completely. So that is the cervical part. And then the esophagus goes into the thorax. When you read about it, they say it runs in the mediastinum. What is a mediastinum? Simply, you're going to have one full lecture by Dr. Akef in the CVP block on the mediastinum. But simply, mediastinum is everything in the thoracic cavity minus the lungs. So if you open up the lungs, everything in between, that is called the mediastinum. One of the contents of the mediastinum is the esophagus. So it's going to run down, and as you can see, it's going to run behind the trachea, but oops, the trachea is going to end here at the level of T4. Why? Because it's going to divide into two bronchi, right main bronchus that's going to go to the right lung, and left main bronchus that's going to go to the left lung. So what do we have here just below the bifurcation of the trachea? What do we have here in front of the esophagus? We have the heart, okay? So whenever you have an enlargement of the heart, people with cardiomegaly, right? What you're gonna have, it's gonna compress the esophagus, the patients would have difficulty in swallowing. So that is the thoracic part. It's gonna go behind the trachea and then behind the heart, in particular, the left atrium of the heart. Okay, then destination of the esophagus is the abdomen because it's going to join the stomach. So what separates between the abdomen and the thoracic cavity? This structure, diaphragm. So we have three important openings in the diaphragm. One for the inferior vena cava, it comes from the abdomen, goes into the heart, and one for the esophagus. You can see it, you know, going through what we call the right crust of the diaphragm. It forms like a sling around the esophagus. Whenever they contract, whenever you strain, you carry something, that's going to contract the diaphragm, right? So it's going to close the esophagus so that food does not go up or backwards. Okay, so we have three openings, one for the esophagus, one for the inferior vena cava, and one for the aorta. Aorta goes all the way, the heart, arch, thorax, and then into the abdomen. So three major openings at the level of T8, T10, T12 for the inferior vena cava, for the esophagus, and for the aorta. Going through the diaphragm with the esophagus through the esophageal hiatus. Hiatus is an opening, right? We have the vagus nerves. These vagus nerves, right and left, coming down, and their destination is the stomach and the gastrointestinal tract as well, right? The abdomen. So they're going to go with the esophagus through the esophageal hiatus or opening into the abdomen. Okay. Now the last part of the esophagus is the shortest, is about ½ an inch, and 1 to 1.5 centimeters. This is the abdominal esophagus, and it's going to join, what is that? The stomach, okay? Now, this lower part of the esophagus and the joining part of the stomach is called the cardia, or the cardiac region. So that's why the lower esophageal sphincter is called the cardiac sphincter. Lower esophageal sphincter is a physiological sphincter. If you touch it, you hold it, you don't see any thickening of the muscles. Why? Because it is controlled by autonomic nervous system, sympathetic and parasympathetic. Dr. Peter is going to talk about that. While the upper part of the esophagus starts by upper esophageal sphincter. Upper esophageal sphincter actually is formed by a muscle, cricopharyngeus muscle. So if you touch it, there is thickening of the muscle. Okay, so upper esophageal sphincter, it is formed by a muscle, cricopharyngeus muscle, and lower esophageal sphincter is basically physiological sphincter. Okay, controlled by autonomic. Both of them are, controlled by autonomic nervous system. But the upper one has a muscle, you can feel thickness. Lower one is not also controlled by muscle. So the lower part of the esophagus joins the stomach. This is, the cardiac or lower esophageal sphincter, or this is the cardia, right? And, the border of the esophagus continues with that of the stomach. And here we have an angle. It's called the cardiac angle or angular notch, right? And that is the stomach. Okay. Now, along its way, from where it begins at the level of C6 or below the cricoid cartilage, to where it joins the stomach, we have 4 constrictions. We have 4 places where the esophagus is narrow. And these 4 places are important. Why? Because these are the 4 places, whenever you have a trauma, they are the most prone to trauma. When you follow or ingest a foreign body accidentally, it's going to be stuck in one of these locations. If you drink a corrosive material, for example, these are the areas that will be injured the most, and these are the areas, the common sites for cancer. Okay, what are these 4 areas of constriction along the path of the esophagus? Number 1, where it begins, at the upper esophageal sphincter. Why? Because it is constricted by cricopharyngeus muscle. The second constriction, now it is going to be crossed by the arch of the aorta. So whenever it is crossed by the arch of the aorta, there is the second constriction. The third, it is constricted by the passage of the left main bronchus. It is crossed by the left main bronchus. And the fourth one, where it enters through the diaphragm. Now, if you do an endoscopy, you know what endoscopy is? Like it's a tube with a camera, they insert through the mouth so that they can see the esophagus, stomach, and the duodenum, right? They can measure the distance. Usually between the teeth, the incisor teeth, and the beginning of the esophagus, it's about 15 centimeters. Towards the arch of the aorta, which is the second place of constriction, is about 23 centimeters, where it is crossed by the left main bronchus is about 25 centimeters, and the distance to the diaphragm is about 40 centimeters in adults, on average. When it is crossed by the arch of the aorta at the level of T4, it's crossed by the left main bronchus at the level of T5. To summarize, there are 4 areas where the esophagus is constricted, prone to trauma, corrosive injury, and cancer. These 4 places at the beginning, upper esophageal sphincter by cricopharyngeus muscle. Second, whenever it is crossed by the arch of the aorta at the level of T4. Third, when it is crossed by the left main bronchus at the level of T5. And finally, the fourth one, as it passes through the diaphragm at the diaphragmatic hiatus or opening of the esophagus at the level of T10. Nerve supply, cervical part of the esophagus, including the upper esophageal sphincter, is the inferior thyroid artery, which is branch of this artery, thyrocervical, which is branch of subclavian. I don't know, have you taken these in the foundation block? Anyway, to simplify, it is inferior thyroid artery, okay? Now, as you go to the thorax, the arterial supply to the esophagus comes from the aorta itself. We have 2 to 3 esophageal branches that will supply the esophagus. When you go to the abdomen, it comes from one of the main arteries of the abdominal aorta. It's called the celiac trunk. We're going to discuss blood supply of the GI and details later on. I have my own way of explaining it that will make it easier. Still, you have to do some memorization, but I'll make it easier for you to memorize. But for now, you know, remember that the last part of the esophagus is supplied by the left gastric artery, which is a branch of the celiac trunk from the abdominal aorta. So inferior thyroid, esophageal, and left gastric. Now, remember this now and forever. When it comes to lymphatic drainage, you know what lymphatic drainage is, right? Why do we need lymphatic blood vessels? No, why do you have lymphatic vessels in your body? To drain what? So that can be drained by veins. Excellent. Guys, you know, blood vessels are not hoses, right? Like the renal artery does not go to the kidney and start showering the kidney with blood. Or the hepatic artery does not go to the liver and start showering the liver with blood. It's a closed circuit. So artery, arterioles, capillaries, and whatever leaks out, the nutrients, minerals, gases go to the tissue. Tissue take whatever they need, and this has to go back to the circulation. Otherwise, you will lose your blood and you will have edema, you know, swelling of the tissue if you leave that fluid that filters into the cells. So that has to come back. It comes back through veins, right? That's why we have veins. So this stuff, fluid and small molecules, will go back through the veins. But there are certain large molecules, proteins, that cannot go through the veins because of the structure of the veins. That's why we have more adapting vessels. We call them lymphatic vessels. So they will take these large molecules and whatever is there in the tissue, bacteria, viruses, cancer cells, they will take them. We call that lymphatic vessels. And along the way, we have stations that will filter them. We'll have antibodies, we'll have macrophages. We call them lymph nodes, okay? So lymphatic system is part of the circulatory system. And it is important not because it drains the tissue, but it drains everything else. So if you have viruses, they can spread through the lymphatic. If you have bacteria, they can spread the lymphatics. And also if you have cancer cells can spread through lymphatics. So it's an important route for the metastasis or the spread of cancer. So that's why sometimes one of the first signs of cancer will be swollen or enlarged lymph nodes. Anyway, so we'll always ask you, what is the lymphatic drainage of this organ? So if you're in doubt, generally speaking, lymphatic vessels, they follow arteries. For example, you know, upper part of the esophagus is supplied by the inferior thyroid artery. Lymphatic vessels will follow the inferior thyroid artery to lymph nodes in the neck. Thoracic part is drained by esophageal arteries coming from the Aorta. So these lymphatics will go to lymph nodes along the aorta in the mediastinum and so on. Okay. This is for the future. Now, venous drainage, again, inferior thyroid vein will go to brachiocephalic veins. This is for the cervical part. In the thoracic part or the mediastinum, it's a different system. We're going to study that in detail. But we have two veins. On the right side, it's called azygos. On the left side, it's called hemiazygos, and they connect with each other. Eventually, we have one vein, the azygos. That is the only vein that goes into the superior vena cava. Okay, this is called the azygos. So in the neck, inferior thyroid, in the thorax, azygos and hemiazygos. Now, lower part of the esophagus has two veins. Now we have two venous systems in the body. One general, that we just spoke about. It takes from the organs and bring it back to the heart eventually. And we have a venous system that is designed specifically for the gastrointestinal system. Why do we need a specific venous system for the gastrointestinal system? So that it absorbs, it takes the absorbed, digested and absorbed nutrients and takes them to the liver. So you eat, you digest, absorb whatever you digested, that needs to go somewhere. First, it goes to the biggest factory in the body, that is the liver. So we have a specific venous system that is called the portal vein or portal venous system, just for gastrointestinal system. It takes the absorbed nutrients to the liver. So we have two venous systems, one portal, one systemic. Do they communicate with each other? Do we have connection with each other? Yes, they do. Why do we need connection with each other? What is the idea behind anastomosis? Arteries, they anastomose with each other. In case you have obstruction in one area, blood can be diverted to the other system, okay? They communicate, this portal system and systemic venous system, they communicate with each other in 4 important locations in the body. We'll discuss that later on. But one of the important locations is the lower part of the esophagus or the abdominal esophagus. So abdominal esophagus is going to be drained by 2 venous systems. One portal through the left gastric and one systemic inferior diaphragmatic that goes to the inferior vena cava. Okay. Yeah, and you guys are lucky because this is recorded. Otherwise, you cannot keep up with all of this, right? But venous, this, nerve supply, it's like, a book, but it is simply, we have time. All viscera in the body are supplied by, when it comes to nerve supply, we don't have radial, we don't have ulnar, we don't have, other nerves that you're familiar with for the organs. We don't have a liver nerve, we don't have a kidney nerve, right? What supplies the viscera, the organs? Oh. Yes? And generally speaking, autonomic nervous system. Autonomic nervous system, sympathetic and parasympathetic. Sympathetic will prepare you to fight or flight, you flee. Right, will constrict your pupil so you can see better. All blood will go to the musculoskeletal system. No blood goes to digestion because you want to flee. Right, while the parasympathetic will, as if you're sitting on the beach, it prepares you for rest and relax. Okay. Anyway, so all the organs of the body are supplied by autonomic nervous system. So autonomic nervous system will supply 3 structures generally. What are they? All they are called collectively viscera, the organs. 3 structures in general. What are they? Heart, right? Autonomic nervous system, automatic nervous system. You have no control over it. Can you tell your heart, please give me 70 beats per minute? It's controlled at the subconscious level. So it supplies the heart, supplies the glands, and what? What is common between GI and the trachea and blood vessels? Smooth muscles. Okay, so autonomic nervous system with our sympathetic, parasympathetic, they supply three structures: glands, heart, and smooth muscles. When we say smooth muscles, that is blood vessels, that is the organs, the viscera, that is the trachea, and all of that. Okay. So any organ, what is the blood supply of the nerve supply of the kidney? Autonomic nervous system, sympathetic, parasympathetic. What is the nerve supply of the liver? Autonomic, sympathetic. What is the nerve supply of the gallbladder? Autonomic. Now physiologists, they're going to come and tell you this is going to constrict blood vessels, that's going to dilate blood vessels, this is going to constrict the sphincter, that's going to dilate the sphincter. And the esophagus is no different. So it's going to be supplied by parasympathetic, mostly vagus or only vagus, and sympathetic that comes from the spinal cord. Okay, nerve fibers, pain fibers, they will hitchhike usually with the autonomic nervous system so that they can gain access to your central nervous system. They go backward and they will enter the spinal cord or the brain. So don't worry about this text for you, just to enjoy. Now, lower esophageal sphincter is physiological. It's controlled by autonomic nervous system, sympathetic and parasympathetic. There are certain diseases I would not usually mention because you're still year one, semester one, block one. But I heard it's going to be mentioned somewhere else. So let's mention it. Sometimes the lower esophageal sphincter becomes too tight, does not open properly. And there's a problem with peristalsis, so food does not move backward. So the esophagus dilates, and this is the area of the sphincter constricts. It's like bird's beak appearance, You know how we diagnose problems with the gastrointestinal system? Usually, we ask a patient to drink something white stuff, we call it barium. That barium is going to go down, and we start taking pictures, x-rays, as the barium goes down, and then it will be excreted. It does not get absorbed, okay? So you can see this white stuff showing us the esophagus, and esophagus is dilated. This condition is called achalasia. It's a rare condition. What is more common is actually when you have this sphincter, instead of becoming constricted, becoming dilated. It's called chalasia. Now, when it becomes dilated, what's going to happen? Food and the gastric juice is going to go back to your esophagus, right? It's might cause ulcers, bleeding, stricture, and so on. This condition is called chalasia. Achalasia is constrictor. Chalasia is the opposite, dilatation. This chalasia thing usually is accompanied by another condition that somebody's going to mention to you. It's called the hiatus hernia. You know how the esophagus goes through the, through the diaphragm to reach the stomach? Sometimes upper portion of the stomach goes through that opening of the esophagus. It goes up to the thoracic cavity. It's called hiatus hernia. So usually chalasia, which is the dilatation of the sphincter, is accompanied by hiatus hernia. I have a couple of slides, with more details on these conditions in case they are. See, this is the esophagus. That is the barium, the white material, and it's showing here the esophagus, and that is the stomach actually. It's going through the diaphragm together with the esophagus. This is called hiatus hernia. Now, this is the esophagus joining the stomach at the cardia or the cardiac area. This has nothing to do with the heart. I don't know why it's called cardia, but it's called, cardia. This is the lower esophageal sphincter. This is the cardiac notch, and that is the stomach. Now, if you draw a line from the cardiac notch, horizontal line, the upper part of the stomach above this line is called the fundus. And if you take an X-ray, that fundus is always filled with air, because you eat food, drink, will go down, air will go up. So take a X-ray of the abdomen, you see a ball of dark cloud. These are gases in the fundus. Now, this is the stomach. It has an upper border that is called the lesser curvature, and it has a lower border. We're going to call it what? This is lesser curvature. This one is going to be greater curvature, right? Now, here, this is the lesser curvature. There's an angle here. This is the angular notch. If we draw a line from the angle here or the angular notch, you know, this area between these two lines is called the body of the stomach. So stomach has a fundus, has a body, and the last part is called the pylorus. And the pylorus starts by an entrance that is wide, then it's going to narrow down to a pyloric canal, which is about 1 inch. Okay, so this is the antrum. Then it's going to go narrow down, and here we have a sphincter. It's called the pyloric sphincter. This is an anatomical sphincter. If you go to the lab and you touch it, you feel it, you will feel thickening of the muscles. Sometimes newborns are born with very thick muscle here that completely closes that sphincter. So the baby comes to you, or the mother will come to you, and the baby is vomiting whatever he or she drinks, projectile vomiting, you know, with force. Okay, so they need to go surgically and open that area. So that is the fundus, this is the body, and this is the pylorus. Starts by pyloric antrum, and that's the pyloric canal for about 1 inch. Then it ends with the pyloric sphincter, which is basically thickening of the smooth muscles. Okay, so fundus, body, pylorus. Now this is the lesser curvature, and this is the greater curvature. Now, GI is covered by a serous membrane. Heart is covered by a serous membrane. Lungs are covered by serous membrane. Those of the lung, we call them pleura. Those of the heart, we call that pericardium. And those of the GI, we call that the peritoneum. Dr. Atif is going to give you a lecture on peritoneum. But basically, some organs are covered by peritoneum completely. Others are covered by peritoneum only anteriorly, right? And we have organs that are not covered by peritoneum. Now, the stomach is wrapped by peritoneum. So we have the peritoneum, the serous membrane covering the upper surface here, and we have peritoneum covering it posteriorly. Now, the two layers of peritoneum, they meet at the lesser curvature, and from there, they go as two layers towards the liver. And we're going to call that the lesser omentum. Similarly, the two layers of peritoneum covering the stomach will meet at the greater curvature, and they will hang down as a towel covering the abdominal organ that is called the greater omentum. So if you open the abdomen, the first thing you're going to see is the stomach and this greater omentum. So if you want to see the intestine, you have to lift the greater omentum. So greater omentum will be like a towel hanging all over the gut or the intestine. It acts like a policeman. They call it the policeman of the abdomen. Whenever you have infection, when you have leak, whenever you have an ulcer, tries to go and wrap it up so that it does not spread. Dr. Atif is going to talk more about it. Now, so this is the lesser omentum. This is the greater omentum. Now, this part of the lesser omentum is called the hepato. Hepato refers to the liver. This is the duodenum, hepatoduodenal ligament. And it's a very important ligament because it contains 3 important structures. It contains the hepatic artery, the artery that goes to the liver, the portal vein that goes to the liver, and the bile duct that's going to bring bile from the gallbladder into the intestine. Okay, now what is behind the stomach and the lesser sac? We have a space. Why do you need a space behind the stomach? So that the stomach can expand. This space is part of the peritoneal cavity. Peritoneal cavity is divided into lesser sac behind the stomach, and the rest of the peritoneal cavity is called the greater sac. So the lesser sac is behind the lesser omentum and the stomach, and this is the opening to the lesser sac. It's called Epiploic Foramen. Okay. Now, if you take a look at the inside of the stomach, you will find that the mucosa is folded. It's called rogae, right? Why do you want to fold the mucosa inside the stomach? Increase the surface area for what? For digestion and, absorption a little bit, but also stomach is an expandable organ. Imagine, you have your tiny little stomach with mucosa that is stuck to the wall, and then you eat something big, right? 4 or 5 sandwiches with capsule or something, and the stomach expands. What's going to happen? That mucosa is going to break. So it is folded so that when the stomach expands, it can keep up with the expansion, okay? Now and forever, the gastrointestinal system has 2 layers of muscles: outer longitudinal and inner circular. Outer longitudinal will act like a spring. It's going to push food down. And the inner circular is going to be responsible for peristalsis. Okay. Always, all the organs. Stomach has the same, but it has an additional layer. It has an outer longitudinal and has an inner circular, but it is different. It has a 3rd layer, innermost oblique. This innermost oblique layer is not a complete layer. We have few fibers, not few, fibers that spread mostly around the fundus and the body. Does not cover the stomach completely. And it's only in the stomach where we have 3 layers. Otherwise, the whole gut has 2 muscular layers: outer longitudinal that acts as a spring, and the inner circular for peristalsis. Now this, this shows you, this is the pyloric sphincter. If the circular muscle, is too big, it might actually close the pyloric sphincter instead of controlling it. So you need to go and do surgery and remove part of that. Now, any questions? There are slides related, I know you study daily. You actually study on daily basis? You have to. But these slides on the blood supply and the small intestine, don't worry about them. I'm going to discuss them, small intestine, in the next lecture. I'm going to leave the blood supply till the end so that you have a comprehensive picture and a comprehensive overview. Any questions on the stomach and the esophagus? Yes? Physiological, both they are physiological sphincters, number 1. So you have no control over them. But with the upper esophageal sphincter, there is an added thickness, which is the cricopharyngeus muscle. If you go to the lower esophageal sphincter, there is no thickening of the muscle. Any other questions? No? Yes? Mucosal layer is the innermost layer of the stomach, and Dr. Khalid is going to talk about the histology of these. I said it is folded. Why it is folded? So that, you know, whenever the stomach expands, mucosa will not be, you know, be broken down, right? It's not that, otherwise you will have ulcers, right? And the other thing, to increase the surface area for digestion and absorption. Dr. Khalid, tfaddal. Guys, you can always email me. We don't have office hours. My office is always open. Come and ask your questions or email me your questions, given that it is the stuff that I did not mention in my lecture. Well, thank you and good luck. We'll see you next week, inshallah. And I have my lecture on the desktop. I'll probably upload it to Moodle later on. Okay.